afternoon, everyone, and thank you for joining us at this earlier time because it's very late where Dr. Keszler is in New York. He's in his jammies, ready to go to sleep, but he's staying up to tell us what to do in this horrible condition, PIE. So I can't resist this. I have to do this. This is Martin having a great time in Bali doing a love heart, but you all know him very well as one of the editors with, is it Suresh Gautam of the
Or Gautam, sorry, he keeps
Gautam
going
Suresh?
back and forth about what.
How to call him? Right,
Can't quite
okay.
decide which is his surname and which is his first name. So the sixth edition, it was Gautam Suresh. Now it's Suresh Gautam. It's,
Oh,
take your
okay.
pick. Take your
Okay, but
pick.
we know you're called Martin, all right?
Yeah.
So the seventh edition was out in 2022, assisted ventilation of the newborn, and hot off the press, they're working on the eighth edition, which is due out in 2027. Right. Okay. So I pinned Martin down because the way we're going with our little babies, we are providing care to smaller and smaller babies. And this is a condition that really, for all of us neonatologists is when, we have a little bit of brain explosion with this problem. And as I told Martin, most of us don't have a jet. All right. So how do we treat pulmonary interstitial emphysema without jet ventilation? Apparently, this is a really difficult question for Martin, but I'm sure he'll tell us a bit about it. So as usual in this talk, he will speak for about 35, 40 minutes, and we'll leave a few minutes at the end for question and answer. If you have any questions that you want to ask, just use the reaction button. You can interrupt us anytime. It's very informal, but also type them onto the chat pane so that Martin can address that at the end of the session. He's given us permission to record this. If there's no one doing anything weird and wonderful on this slideshow, like walking around with our clothes on or whatever, right? Then we'll post it onto our WhatsApp group and on our email list after this, and you're free to share it with your friends. Okay, so without further ado, I will hand over the reins to Dr. Keszler. Thank you, Martin. The show's yours.
Let me see. I got the right slides here. Are we good? Can you see?
Okay, you're good to go.
I don't know why this is here. All right. So I got ahead somehow. Okay. So thank you, Julie, for the invitation at this lovely hour. I'm an old man, so I go to bed early, but I'll stay up for you all. Thanks for moving it up an hour. All right. So here we are. And this is a problem, and it's difficult for me to talk about treating PIE without the jet. Now, the topic I was given was with and without. So I'm going to talk about with because I've been using the jet to treat PIE since my fellowship days in early 1980s. But anyway, just to summarize what tools we have in terms of high frequency ventilation. So of course we have the oscillators, which is what the entire world has in the US and Canada and a few other select countries and units. There is jet ventilation, which is what is the primary tool for treating this wicked disease. And then there's such a thing as flow interrupters, also known as high frequency percussive ventilation, which is not widely used. It's mostly a transport ventilator, and a few folks use them. But there's more than one kind of high-frequency ventilation is the point. What all high-frequency ventilation devices have in common is the rapid rate and the fact that the tidal volumes progressively attenuate as you go further down the tracheobronchial tree because there's no time for flow and pressure to equilibrate. And most of the gas exchange with oscillatory ventilation certainly occurs by dramatically enhanced diffusion, moving the zone of diffusion from the respiratory bronchiole all the way up to the large airways. So we have just let me see, I need to okay this so you don't have things on the screen. So pulmonary interstitial emphysema is a problem that we've seen forever. It used to be actually very common in the pre-surfactant days. Most of you weren't born yet in those days. It was a problem that clearly is resurfacing now that we're treating more immature babies. And the incidence of PIE is definitely inversely proportional to gestational age, in part, I think, because of the fact that the interstitium hasn't thinned out yet in these very immature babies. So there is more interstitium to trap air. And of course, they tend to have poor lung compliance. The risk factors we know are high peak inflation pressure and longer inspiratory times. In the bad old days when I was a fellow, before surfactant, there was a lot of high PIP, relatively long inspiratory times, and slower rates. And we saw tons of PIE, lots of pneumothoraces. We got really slick with putting in chest tubes when I was a resident and fellow. But of course, then things got better and we had surfactants and we got smarter about ventilation. And we were not seeing that much PIE. And now we're seeing more of it, as Julie pointed out, because these extremely immature babies who air trap, and it's a problem. Bilateral PIE is associated with high mortality. Unilateral, not so much. Unilateral can usually be treated successfully and resolves. The studies of how to treat PIE are all old, very old. And really, there hasn't been anything material more recently. I will share with you what I found, and I looked really hard for anything other what I already knew, which was when you have a jet, you use a jet to treat PIE because it works. So how does air get into what is PIE? How does it get there? So by and large, it's rupture of the alveoli with dissection of air into the perivascular sheath. And of course, the vessels, as you know, follow the airways. And so you've got this air trapped around the airway and the vessels. It interferes with venous drainage, lymphatic drainage. It can compress the airway itself and result in worse air trapping. But importantly, because the air is being collected in the perivascular sheath, which follows the airways, the classic picture of PIE is these linear sort of branching lucencies. Classic PI is not round. It's more linear like this one. This is, of course, a unilateral case, but this is what typical classic PIE looks like. It can, look like that on the other side. I don't have a good picture of really bad bilateral PIE. And again, in the bad old days when I was a fellow or a young attending, we were getting referrals from other NICUs with horrible bilateral PIE with tremendous air trapping and overexpansion. And we were getting those referrals because we had the jet and other people didn't. So they sent us babies and we would put them on the jet and things tended to get better, which was kind of the basis for subsequently doing a randomized trial. But not everything that is a lucency in the lungs is PIE, although radiologists tend to call it all PIE. There are reports of these cystic lucencies evolving very early on in babies with chlamydia infection. And this is probably actually early cystic changes. These babies go on and very rapidly develop changes of bronchopulmonary dysplasia. As early as the first week of life, you sometimes see diffuse bubbly lucencies everywhere. And our radiologists will always call it PIE. And I'm like, that's really not PIE, although I might treat it with the jet anyway in my hands. But it's probably not actually PIE. some of these babies just go into a very early, very rapid progression if they've been exposed to in utero infection. As you know, that can trigger the process of inflammation and repair in utero and present very early on. So is this amenable to high frequency? Not always. So not everything that looks like PIE actually is PIE, but treatment may be somewhat similar. But not everything that looks like it's called PIE actually is PIE. So this should really say prevention and treatment to some extent. So obviously we know the long eye time and high PIP are risk factors. Very high PEEP or inappropriately high PEEP rather potentially can lead to air trapping and at least look like PIE. If you have a baby who's starting to develop some PIE, just we would typically shorten the eye time, try to wean the PIP, and try to be as gentle as we can, accepting higher CO2, accepting higher FiO2, not trying to optimize lung inflation so much because we're trying to deflate the PIE, trying to let that air be absorbed. But it's tricky to find the balance between decompressing the PIE and getting complete atelectasis. So that's somehow tricky. And so you don't necessarily want to drop the PEEP too much and just collapse the lung, because then you're going to need those higher pressures, which is going to blow the PIE back up. So you don't want to do that. So in general, places that have a jet will use the jet. And I'll show you why. What the evidence is. If you have unilateral PIE, it's easier to deal with because simply positioning the baby with the affected side down will often resolve it over a period of a few days. If it doesn't, or if there is tension, if there's significant mediastinal shift, and if the baby is large enough to tolerate it, intubating selectively the opposite mainstem bronchus to try to do single lung ventilation and allow the PIE to resolve. It works if you can do it. Obviously easier to do on the right side than on the left side, but it's doable. There are tricks to do that. And there are tons of case reports of 2 or 3 babies. Hey, we treated them with mainstem bronchus intubation and it worked. Great. I mean, there's a slew of them, but all little anecdotes. And, I've done it and it works for unilateral PIE. If you're not careful, you're going to induce PIE on the other side if you're putting too much volume into that single lung when you're intubating, when you're ventilating just one lung, obviously. People have also reported if you're not able to intubate selectively, mainstem bronchus is to use a Swan-Ganz catheter to occlude the mainstem bronchus on the affected side and thereby selectively ventilate the good lung. Perhaps in combination with positional therapy, you need to be kind of careful with that, right? Because you could certainly induce mucosal damage. The reason we don't use cuffed endotracheal tubes is the pressure from the cuff causing mucosal damage and subsequent subglottic stenosis. So the same thing can happen in the mainstem bronchus. So this is not, there's only a few case reports, and this is not something I've done or that you would want to do very frequently, but desperate situations call for desperate measures. If everything else is failing, that's something people have done, have reported. Again, this is certainly not your first line indication. All right, so the jet, I'm sorry that you don't have it. If you can get your hands on it, it would be great. The jet is a gizmo that in various forms I've used for 45 years. And the jet was actually introduced, this form of jet ventilation, the Bonnell life pulse, had been introduced in mid-1980s, so it's an antique. Just like the sensormatic oscillator, which some of us still use. And it has this little pinch valve. There's a pressure head of gas, and it opens the pinch valve just very briefly and allows a pulse of gas to come down into the airway via this jet injector port. There's a distal, there's a pressure monitoring lumen, which senses the pressure near in the endotracheal tube and feeds it back. This device was made to mimic pressure controlled ventilation because in the 1980s, that's all we did in neonates. So it's got the servo feedback that makes the volume of gas being injected here vary to maintain a set PIP, which is probably, in retrospect, a bad idea. Try to convince Bert to abandon that. There's a new version, but it functionally is exactly the same. But the way the jet functions is basically squirting that stream of gas, pulses of gas down the center of the airway, displacing the gas, the exhaled gas sitting in the dead space here, so some of its effect is because of bypassing of the dead space of the upper airways. But some of it is simply by streaming of that gas through the center of the airways with minimal, if any, lateral pressure on the tracheal wall. You can actually cut a hole here and not lose any significant amount of gas. It's critical to keep the head straight when you're using the jet, because if the endotracheal tube is kinking the trachea, as in this picture, you will obviously break up this stream of gas, and it's not going to work so well. But one of the cool things with the jet, because that jet stream can really be directed in random directions that you choose, you can do what I call virtual mainstem bronchus intubation with it. You can, so this is a case, one of several that I've used this trick on. There's tension PIE. You can see the film is a little bit rotated, but there's definitely some tension here with the contralateral lung being squished and poorly aerated, mediastinal shift. You turn the head to the opposite side. You advance the endotracheal tube close to the mainstem bronchus, but not right into it, because at least in our little tiny babies, there are no tubes small enough to actually intubate the mainstem bronchus. Even the 2.0 is probably dangerously large, and you can avulse the bronchus. But with the jet, you can do a virtual intubation by directing that stream of gas. And in a matter of 12 hours, this is not totally resolved, but it's certainly better. The tension is gone, and there's still some residual interstitial air, but much less so. So it's one of those cool tricks. I mean, this was the first jet I used, homemade injector. We've come a bit of a ways. We've moved from late rescue, which is how we started, of course, before knowing that it really works and that it's safe, to earlier rescue. Oops, I'm going backwards. And ultimately, now in the very premature babies, there is a trend in the US, at least, to use jet ventilation as a first line, first intention treatment for those extremely immature 22, 23-week babies. And it appears to work, but the evidence is anecdotal for that. But so equipment has evolved a little bit, and our practices have evolved over time. So the jet can do everything the oscillator can do when used with very appropriate strategies, but its primary use in where people have both jets and oscillators is to switch to jet ventilation when there is air leak, specifically pulmonary interstitial emphysema or pneumothorax with persistent leakage through bronchopleural fistula or tracheoesophageal fistula. There are other indications that I'm not going to get into, but we ran a randomized trial a very long time ago, but there hasn't been any other randomized trial really since then. And what we did was, because there was pretty good evidence at that point already that anecdotally jet ventilation can rescue babies who are really doing poorly with conventional ventilation and cannot be ventilated. So we ran this randomized controlled multicenter trial, but we had strict criteria for failure and an opportunity to cross over to the other arm if those strict criteria were met. And so, which is why the outcome is success, meaning meeting the success criteria. rather than survival. And you can see why in a moment. So there was significantly more babies who reached success criteria. And I will show you in a moment that if you met success criteria, you survived. Then with conventional ventilation. So overall, in the subgroups, obviously, you lose statistical power. So not all of the differences were significant, but it seemed to hold reasonably well across the gestation of the size strata. This was very long ago, before surfactant. So we saw a lot of PIE. In fact, I started a randomized trial as a fellow in our single, now in 60-bed NICU. And then we changed the way we ventilated, and PIE sort of dropped off. So what happened if you were assigned to conventional ventilation, randomized to conventional ventilation, and met the failure criteria? Well, almost half the time, there was a very good response. We were obviously at this point kind of late in the course of these babies. The failure criteria were pretty rigid. Nearly half of them eventually succeeded and were able to wean, and almost all of them survived. Significant portion had at least transient improvement, but maybe it was too late at that point, and only a small percentage continued to do poorly after crossing over. If you randomize to jet ventilation, and the smaller number that failed jet ventilation were crossed over to conventional ventilation, almost all of them continued to fail. And if you failed, you died almost all the time. If you met the success criteria, you survived almost all of the time. So it kind of validated the failure criteria as being appropriate. And of course, we were, criticized for this crossover. This was not pure. This is not, conclusive, because there was all this, crossover. But hey, these are live babies, and death as an endpoint is a difficult endpoint to do in clinical trials. And these are just some values of peak inflation pressure. The conventional arm, started around 30 and went up, if anything, a little bit. With the jet, he was able to drop. CO2, very nice response. The jet can ventilate a rock, and oxygenation index and other things, basically, were all improved. So this is pretty much the basis on which anybody who has access to a jet and has a patient with PIE will switch to jet ventilation, because it does work. Why does it work? So the unique thing about the jet is that it uses an extremely short inspiratory time. It just shoots a little bullet of gas down the airway. And, there's certain impedance. You probably need to reach a certain pressure before you really start blowing gas through a hole. And with conventional ventilation, obviously, the inspiratory time, the period of time that the pressure is above the whatever critical threshold there is going to be a lot longer than with the jet, with these very tiny, short inspiratory times. But with the low PEEP approach that we initially used, you ran into a problem with atelectasis. So you were trading one problem for another, and if you overdid the low descending pressure approach, you ended up with diffuse atelectasis. Maybe the PIE resolved, but now you've got a lung that's needing to be opened up, and obviously has worse compliance. And so you might be making the same, blowing the PIE back up, and that's not what you want. So it turns out that it's actually okay to use a higher PEEP, because the inspiratory time remains so short that even though you are using a more appropriate descending pressure and therefore have better inflation of the alveoli, you still aren't losing a lot of gas into the PIE, and eventually over time it resolves, it reabsorbs if you stop pumping additional gas into it, and that's why it actually works. It's a unique gas flow pattern that's different from oscillatory ventilation. So this is another story. I'm not going to get into that. So we also have information about use in other forms of air leak. So, for example, This was a small, just observational study. Babies who had large bronchopleural fistulas with a lot of air leakage through those tubes switched to jet. There was an improvement. It didn't totally go away. Sometimes it does dramatically drop. Sometimes it drops modestly, depends on a variety of factors. And then we had this baby with tracheoesophageal fistula, who had a very large, it was a small preemie, a very long time ago. For 1992, that was kind of borderline viability. And this baby had a very large fistula. The gut blew up immediately. We got the surgeon to do a decompression gastrostomy. But now half each tidal volume delivered by conventional ventilation was going out the gastrostomy tube because of the size of the fistula. So we were having a hard time ventilating this child. Oxygenation was miserable. And this was despite trying to use the lowest mean airway pressure, fast rate, short inspiratory time, the things that you normally try. We were 100% oxygen, and there was a lot of air coming out of the gastrostomy tube. So I quickly measured the airflow before we switched to the jet. And then we switched to the jet, and you can see the gas exchange improves pretty dramatically. And we were using fairly fast rate, but it's this very, very short inspiratory time. I think that makes the difference. So that's why air leak is the biggest thing, and it's really amazing. You with conventional ventilation, if you pressurize the airway, air is going to come out the hole. With the jet, where the gas is streaming down of the airway, you don't get that big leakage. And we've done this in the lab. You can cut it 1 centimeter square into the trachea of an experimental animal and jet right past it, and very little gas comes out the hole. So it's got unique gas flow characteristics, which is why it works. But I know you don't have it, so I'm just trying to whet your appetite. So maybe you'll be motivated to get some. The jet's kind of historically had a better reputation in terms of oxygenation, but that was strictly a function of the inadequate distending pressure that people tended to use. The inspiratory time is so short that the mean airway pressure is really driven by the PEEP. And if you're PEEPophobic, like so many people are, PEEPophobia is one of my things. I've been fighting PEEPophobia for several decades with limited success, but maybe some. So Gabby Musk in your country, in Australia, did this work with the jet for her PhD, and she demonstrated that if you use enough appropriate higher and dynamic PEEP to optimize lung inflation, you don't have that progressive rise in FiO2 that you have if you use not enough PEEP. That shouldn't be a surprise. It turns out that the tools we use are less relevant than the strategy that we use. And whether it's a jet, an oscillator, or a conventional ventilator, mean airway pressure is all about oxygenation and ventilation perfusion matching, and pressure amplitude is what drives ventilation. Again, whether it's an oscillator, the jet, or a conventional ventilator. So people make a lot of fuss about this. This is great. This is what works. It's not what you use. It's how well you use it or how poorly. So the jet can be used with a more optimal distending pressure and have good oxygenation. So, which is why I say the jet can do pretty much everything the oscillator can do, and some things you can do better. So if you only had one high frequency ventilator, you would want to have the jet if you could get it. I'll have to talk to Bert and see what you can do. And this is just confirming that also lung compliance was improved with more optimal lung inflation using more optimal PEEP with jet ventilation. But so if you had the jet, and a few of you might perhaps, if it's a unilateral, it's relatively easy, and they almost all survive. With the jet, you can do that virtual mediastinum bronchus intubation. So even in very small babies, you can treat unilateral EIE without risking avulsing the mainstem bronchus by trying to force a tube that's too big for it. And with the jet, and turns out perhaps with the oscillator as well, lower frequencies are appropriate. So with the jet, we talk about actual rate as opposed to frequency, but this would be 5 to 6 hertz, to allow longer expiratory time, to allow decompression of the PIE. And same as with every other strategy, you accept higher CO2, higher oxygen requirement. The jet has the ability to superimpose side breaths, but we obviously don't do that when we have air trapped along with PIE. And again, if we do it too well, we end up with more atelectasis that then requires us to go back up on the pressure, and that becomes counterproductive. So we no longer are so PEEP-phobic even in the face of PIE. Although I will tell you that the study that we did, that we published in 1991 that I showed you, we used the lower PEEP. And so we fought atelectasis all the time. All right, you don't have the jet. Now what? So I looked really hard to see if I was missing some data to support other approaches, and I didn't find a lot. But I will share with you what I did find, and if any of you know more about other studies that I missed despite my diligent search, please do let me know. What is out there? I mean, we do it. Lots of people do it. Not everybody in the US has a jet either, although they could if they wanted to. So if they don't have a jet, they typically use oscillatory ventilation. And, it does seem to work, they say. But what are the data? What's the objective evidence for the benefit of oscillatory ventilation? So I'll share with you what I found. So the earliest thing I found was 1986 in pediatrics, critical care medicine, I'm sorry. A case series, 27 infants with PIE. There were no controls. 16 of the 27 survived. That's not great. Survivors, not surprisingly, had improved gas exchange and were able to wean. Non-survivors, you guessed it, they continue to deteriorate and die. For some reason, the authors concluded that HFOV is effective, and they hypothesized or speculated that it's due to the lower distal pressure swings, and that may be true. But I mean, I don't know about you, but I'm not that impressed with the data. I mean, we know that PIE gets better spontaneously in some babies if we, tweak the ventilator settings, even on conventional ventilation. There were no controls. I don't know. These kids were apparently fairly sick, but I mean, this is not entirely convincing, right? It's an observation. But, back in the day in 1986, that was publishable. Then there is a paper following year in pediatrics about the use of high-frequency percussive ventilation. So this flow interrupter, this brainchild of Forrest Bird, who is the guy who invented the first neonatal ventilator, the baby bird, that none of you are probably old enough to have used or to remember, but it was a great little gizmo. So this was called a pilot study, a case series of 9 infants with what was described as severe PIE, treated with this percussive ventilation. 5 of the 9 survived, so a little more than 50%. All had severe BPD at the end. The comparison group were historical controls. There was no meaningful statistics that you could really do. They had data that, bilateral severe PIE has high mortality. Well, it does. Gas exchange did improve, at least transiently in all babies, and the chest X-ray improved in most of them. But the funny thing was their baseline, unless this was a typo in the manuscript, their conventional ventilator settings were crazy. They were using a really fast rate. And we know that with conventional ventilation, if you crank up the rate to greater than 90 or so, you're guaranteed to air trap. So some of this bad PIE may have just been their inappropriate ventilator settings, and when you change to something different, maybe things improve. Sadly, all autopsied infants had severe tracheal injury because they were using really high pressures with this gizmo. And again, for some reason, they concluded that percussive ventilation is effective. Case series of 9 is not entirely convincing, but that's so far what I was able to find. There was also a clinical trial. This was the one randomized controlled trial, the so-called high-flow study. Many of you probably are familiar with it, which was essentially, unlike some of the many of the oscillator studies, which were first intention, more preventative approach. This was a rescue use in babies with severe RDS in many complicated by air leak. So a lot of babies already had air leak at entry. And it did not seem to progress so much. But there was really no difference to speak of between high frequency and conventional ventilation. So there wasn't really any convincing evidence that you actually can resolve air leak more rapidly. There seemed to be a little bit of less new air leak, but most of that was in the mild category. So if you didn't have air leak to begin with, most of them did not develop air leak. There were some high number of new air leak in the mild category was conventional compared to high frequency. But in terms of preventing progression or having resolution, that did not seem to really be occurring here. The only 21st century study is one in neonatology, a journal called Neonatology by Squires, published in 2013, where they had, again, just a case series, treated with HFOV with a low frequency. And they argue that that is more appropriate because you have longer expiratory phase, which allows resolution of the PIE. On the other hand, to maintain the same minute ventilation at lower frequency, you need a larger amplitude, in other words, a larger tidal volume. Actually, of course, you don't actually have a large necessarily, whoops, I'm going backwards. I apologize for the preview. Of course, as you all know, when you decrease the frequency, you get a larger tidal volume without changing the amplitude. So whether that's really the right answer or not, I don't know. It's 19 infant case series, no controls. But 10 of the 14 with the bilateral PIE survived. They had 5 babies who only had unilateral PIE, and they all survived because that's what typically happens. Unilateral PIE, if it doesn't progress to bilateral, does not have high mortality. Most of the babies, there was an improvement in gas exchange, and graphically looking at so they had relatively high mean airway pressure, which they were able to lower once they switched to high frequency ventilation, and perhaps that's what helped. When they switched to high frequency at the low frequency, high frequency, so to speak, they had to drop the amplitude probably because they were overventilating those babies because of the larger tidal volume that you get at lower frequencies. For the unilateral cases, it actually seemed to go in the opposite direction for reasons that aren't entirely clear to me. Their gas exchange improved marginally. And so they say, this is great. This is what you should do. That's probably, I mean, this is the most recent evidence that is a little bit limited, but perhaps this is the way to do it. But that's what we have. I could not find any other studies. Anecdotally, people tell me that, yeah, I mean, we do it and it works. And they point to some of these old studies with case series without controls, which is a little bit less than convincing. But if that's what you've got, these are your options. So treating PIE without the jet. I have to tell you, I don't have personal experience because I've always used the jet for PIE. In our randomized trial, we did this in the conventional group. In other words, those babies are randomized to continue conventional. We used the more rapid rate, short inspiratory time, lowish PEEP. In fact, more low than what probably we would recommend now. And that was in the controls, and they did not do as well. But, PI does resolve if you manage to avoid making it worse. There's one study that says PIE was resolved with steroids. Well, it was probably the BPD that was resolved, but anyway, that's out there too. And you become less ambitious about the gas exchange and optimizing lung inflation, but you got to be careful again about not letting the lung collapse. I can't emphasize that too much because people tend to do that, and now you've got a lung that's stiff, and you need to crank up the pressure, and things blow up again. So it's a fine balancing act, but that's basically all we've got. And tincture of time and the fact that newborns are incredibly resilient. And if we don't make them worse, they will typically get better. And we sometimes take too much credit, but that's okay. We also take too much blame. So if it's a unilateral situation, you're in good shape because those babies almost always get better. You have several options. And again, this positional therapy was described back in the 70s and 80s, and it does work. You're simply using gravity to help you. So you position the baby with the affected side down, the mediastinum, the weight of the mediastinum helps decompress or correct the overexpansion, the tension, and you obviously will have some transient deterioration in gas exchange, especially if you had tension, PIE, where the good lung, quote unquote, good lung has become atelectatic. You will transiently, have some problems, but you will be able to improve ventilation perfusion matching by positioning the baby with the affected side down, and over time things tend to get better. So that's probably your first choice if you have unilateral PIE. And some people have argued, well, you can do this even with bilateral PIE. You sort of fix one lung at a time. I haven't tried that, but perhaps that's an option. So if that doesn't work, and maybe you just need more patience than most of us neonatologists have, because as we all know, self-reflection is important. We're a bunch of adrenaline junkies that like instant gratification, right? So patience is a virtue I'm still trying to acquire. But if you give it enough time, usually this actually works. If it doesn't, if the tension is too severe, or the baby does not tolerate the positioning, you have the option of selective mainstem bronchus intubation. Obviously, that's hard to do in a 22-weeker because even a 2-millimeter tube is probably too large to intubate the mainstem bronchus, which is where the virtual intubation is a really cool trick. So you selectively intubate the good lung, and hopefully you allow decompression of the tension PIE on the other side. And often you will fairly rapidly get resorption of the air and resolution of the PIE. It has been suggested, based on a literature review of all these different reports, small case series, usually 1 to 5 cases, that you should probably leave, if the baby's tolerating it, leave the mainstem bronchus intubated for about 48 hours. to avoid recurrence of PIE if you're too impatient and pull the tube back into the trachea. As soon as the PIE resolves, it'll probably recur. So the suggestion is to wait for about 24 hours after the resolution of the PIE before you challenge the affected lung again. Again, I mentioned before, people have reported balloon occlusion of the affected side, brainstem bronchus. It makes sense logically. It apparently worked in those cases, in those few cases that were reported. But there's a risk of mucosal damage. People have done crazier things. People have taken long needles and poked through the PIE lung and decompressed it into the pleural space and put in a chest tube, and that apparently did resolve. And there, I have to say, there were babies with really wicked bad PIE where I was tempted to do that. Never actually did, but those case reports are out there. And if you don't have a jet, you have an oscillator. People have used it with apparent success. The data are mostly anecdotal. Perhaps the low frequency is the right trick, but I do worry about maybe your amplitude's going to be, or your tidal volume is going to have to be bigger in order to maintain minute ventilation at these lower frequencies, but maybe not that much bigger. So this is probably the best recommendation. Jonathan Klein in Iowa likes to use a 1-to-3 IE ratio. Obviously the Sensormedics can't do that, but the modern oscillators available everywhere except in the United States can do 1-to-3. And so and a relatively low, of course, a relatively low mean airway pressure and a relatively low rate as well to optimize the expiratory time. As you know, the jet the oscillator has active exhalation, but you need to also allow the passive, one of the problems with PIE, it actually can obstruct the bronchus because it collects in the perivascular sheath and around around the small airways, potentially causing some obstruction. So you may need that longer expiratory time so that the negative pressure, as you know, if you have a 1-to-1 ratio, the positive pressure swing is equal to the negative swing. In other words, you're sucking equally strongly as you're pushing the gas in. If you have a 1-to-2 ratio, you have twice as long period of time. And so the negative pressure that needs to be generated is going to be less because you have more time to remove that same volume of gas. And 1-to-3 will give you even longer expiratory phase and therefore less negative pressure, which is less likely to contribute to the air trapping by collapsing the small airways. So that makes some logical sense to use that 1-to-3 IE ratio. Again, that's anecdotal stuff from Jonathan, who has a lot of experience with jet ventilation. I'm sorry, with oscillatory ventilation. He has a lot of experience with jet ventilation, but when he uses the oscillator, this is what he does. And again, the least ambitious gas exchange, minimal distending pressure and amplitude, obviously no size if you have an oscillator that can do size. And again, you want to avoid atelectasis if you can. Your other options are, I already gave away my punchline here. But there's not a lot of other options. This is what the literature is, and it's pretty scant. And somebody ought to do more recently because we really have very little. We have stories, we have anecdotes, we don't have very good data. And frankly, my data from the 1990s, is it really 1980s is when the work was done, published in 91. There was a different population. Is this truly applicable to our patients today? And I can tell you that we, of course, still use the jet in our modern population and it still works. But in terms of taking literally the randomized controlled study from 40 years ago, you could argue is also of somewhat limited value. But it does work, it does continue to work. So if you have access to it, that would be the first choice. If you don't have access to it, I could not find a whole lot other than things that we talked about, that we have tricks unilaterally is relatively easy to fix. Sometimes staying on conventional ventilation and not making things worse will allow it to get better with some time. Certainly trying the oscillator with these caveats is probably very reasonable, but I could not find a lot of good data to support this approach. But anecdotally, people who don't have a jet tell me that, yeah, we use it and it seems to work. I would love to have stronger evidence, but that's what we got. So I'm sure there'll be lots of questions and discussion, but that's where I ended up when my funding ran out. Just kidding. That's Charles Bridge in Prague, where I grew up. So thank you, and I'm happy to do questions. Did I stay? Oh, I
No,
talked to
no,
you.
all perfect. We have about 10 minutes of questions. And there's been a lot of activity on the chat about who actually does have a jet ventilator, Martin. And it sounds like it's David Tinge from Children's in Melbourne and the KEM, the King Edward Group in Perth. And that's about it. And Wes Smith is asking whether you have shares in the bundle. You
I
don't.
do not.
You
I
do
have
not. There you go. Yeah.
I have saved Bert Bonnell's butt on a couple of occasions, once literally and once figuratively. He owes me more than I owe him, but I do not have any shares. I just share what I know, the data that are out there,
Perfect.
and why. And hopefully I adequately explain why it actually does work. And no, I do not have any shares.
Oh, and Becky Thomas is saying in Perth Children's Hospital. So my question, I guess, before we open up the floor is, since we're providing care to tinier and tinier babies who seem to have, like, start off life with PIE, right? Should we all have a jet as a as a first line ventilation?
So yeah, I don't think we know, right? But in the evidence for what the best ventilation approach to these extremely immature 22, 23 weekers is not strong. There are no comparative studies. There was this nice review paper that presented data from 3 different places that use different strategies and all have excellent results. One uses conventional volume targeted ventilation, one uses the oscillator, and one uses the jet. That's Sweden, Japan, and Iowa in the United States. There has been a lot of interest in adopting the jet as a first-line treatment for these extremely immature babies, but I argue that it's not what you do or what you use, but how well you do it, how well you use the tools at your disposal. And that's probably still true for really everything we do, including treating PIE. So if you're really careful and slick with your oscillator approach, you can probably treat PIE successfully. There are lots of situations where people are using an excellent tool the wrong way in the wrong population and having bad outcomes. So paying attention to who the patient in front of you is and paying attention to what the baby's trying to tell us, because babies do tell us if we know how to listen.
Okay.
So yeah, so I don't think everybody has to have a jet, but if you see a lot of PIE and if you can get a jet, I would still suggest that is the best evidence supported and physiologically plausible tool that would help resolve PIE. But again, if what you have is an oscillator, you probably can use it with those caveats and with great care to find the fine balance between low enough pressure to allow the air leak to resolve, but not so low that you develop diffuse atelectasis and then you start over, and that's not where you want to be.
Okay, so we've got two people who have raised their hands, and they're probably the only ones in Australia with experience in the jet. So I'll go on to David and then Andy next. Yeah.
Well, firstly, I'll say the RCH has got many consultants, so I'm not going to say that I'm the only one
No,
with
no, no, no,
experience
no.
with the jet.
You
So,
represent everyone. Yeah.
yeah. So I'll make a couple of points. Most of them are actually agreeing with Marty. Firstly, I think we just got to remember that PIE, not every PIE is the same. It is a continuum of a disease. There's early PIE, late PIE, and somehow we've forgotten about middle PIE. We ignore it. And I think maybe what Marty's been saying very clearly is that it's not the machine, it's the user and the understanding of the disease that's important. I think in early PIE, probably the benefit of the jet in terms of normalizing gas exchange is not too great over the oscillator, although Andy's going to say that's not the case. But I think probably in gas exchange, it's no different. But in lung protection, I think it's particularly different. And I think in cardiac protection, it's particularly different because we haven't talked about the effect on the hemodynamics of the differences in applied mean airway pressure. I think when you look at all those case series, they're very much focusing on late PIE, where for us that have used the jet for a long time, it's a no-brainer. As you said, if you've got the jet, you don't really have other strategies because you don't bother with the other strategies because you just put them on the jet. So I think we've just got to understand where that is. And I personally, my opinion is that we should offer it as a therapy, at least in regions across Australia. We shouldn't have the position we're in now. It needs to be a regional service so that the equity is there. It is not the same as just buying a different brand of conventional ventilator. And I think Andy will agree with this. The experience of starting up with a new therapy is not small. And you really need to approach it with the right mindset. So you don't go in and say, great, I'm going to buy this great new machine that I was just told about. It's actually a whole program of care. You need a long time to set a program up properly. I would just put that as a caveat. Very supportive we do it, but don't go and rush into it.
Great, thanks. Maybe we'll move on to Martin, your comments, and then move on to Andy for his comments.
And I totally agree with David. It's a severe PIE that's really a problematic thing. You can reverse the early PIE with adjustments to your conventional approach or with the oscillator. And yes, it takes you got to do it right. You don't just bring in a new machine. That point is really important.
Thank you, Andy.
Yeah, thanks, Marty. Very interesting area. We are wedded to the jet. I cannot imagine running a unit without a jet ventilator. And probably 50% of our ventilator time is on jets. That's not babies. We generally start on conventional, but the indication for the jet is really those babies that have got dishomogeneous lung disease, or those babies who are going through that phase after about 48 hours when the oxygen increases. And you want to be lung protective. And as David says, there are many other ways of doing it, but I think the jet is really lung protective. I'm not surprised there's no evidence out there. We could not do a trial now because we wouldn't know what to do with the control group. So it's just not there. And I think the other thing that keeps coming out, and David said it, I'll say it again, it's how you use the tool that is really most important. And it is a big learning curve to get the jet to work. We tried in Perth. Jane Pillow introduced it back around 2000 and it failed. We didn't do it. We went back. We got Bert over. We spent a lot of time, a lot of training on all our staff, medical and nursing. And now we've got to the stage where we just would not use anything else. Evidence, difficult to find. I always, and I keep saying this, for me, physiology tops any trial. And I think there is quite good physiological evidence that the jet is lung protective and is a safer way to ventilate, particularly if you get your lung volumes right. And we're increasing using lung ultrasound to get the lung volume right. other thing is, which is interesting as far as evidence is concerned, if you look across ANZNN data, Perth has the lowest incidence of BPD, and certainly the lowest incidence of severe BPD that goes home on oxygen or is still ventilated at term. It's not just the jet, there are many other things, and it's not a trial, but I think the jet is at least playing a part in that. The other quick comment I make is, yes, I did use the bird. And yes, I have in the past, many, many years ago, scarified lungs with severe PI and with some effect. So those are still there. But I guess, as David was saying, the jet is really preventative rather than anything else. And it stops you developing that severe BPD once your lungs are starting to become dishomogeneous. You can't buy one, you'd need several, and you need a whole training program to introduce it. And I think this is where some of the trials go amiss, is that people buy them and think, oh, we'll start it in the trial, and you've really got to spend some time learning how to use it. And by the time you've done that, you can't do a trial.
Right. And just to be sure, you don't have stock in Benelli either, right?
No. No.
But I couldn't agree with you more.
Any other comments from anyone else? Leah Hickey saying that, you know, she emphasizes that there is definitely consideration needs to be given to the workforce, nursing, medical tech. Totally agree. Maybe you guys can set up some workshops. And Rachel saying, can you not do a cluster randomized trial? 80% of the units don't have a jet and don't know how to use it. Rachel, that's the problem. Would love to buy a few.
Yeah.
There is a question on what from Thailand about how to use HFOV if you don't have a jet, like with VG, without VG, you know, if you're in deep trouble with PIE. Any thoughts on that?
Yeah, so I would, you know, if you have the oscillator with VG, I would always use VG. There's no downsides to using VG. The other caveats would be, you know, minimizing the pressure, obviously aiming at relatively, you know, some degree of permissive hypercapnia and all of that we talked about, and maybe the lower frequency is the right answer. But other than that, yeah, sure, I would absolutely use VG.
Okay, so we're at the hour. Oh, one last question. Simone, yes, feel free to unmask yourself and ask the question.
Yeah, I'll try to make that work. Can you hear me?
Yes, of course.
Hear
Yes.
you.
Excellent.
We can see you now too.
Hi, I just wanted to add to what Andy said. I'm also at King Edward, and I really thought coming from a unit where we didn't have the jet in Europe, it was a big learning curve for myself, but also really quite impressive to see what you can do with the jet for the babies, not only with PI but also with chronic lung disease. And in this context, I think the value of lung ultrasound, which we nowadays use more and more, just really wanted to, I guess, mention it at least, because I think if we talk about PEEP, inflation, what's enough, it's just really helpful to have that tool as well. Thank you.
Yeah, no, I totally agree with those comments, and the jet is a really good tool. It does require a fair amount of training to know how to use it well, but it can do a lot of things, and yeah, the lung ultrasound is clearly a tool that we need to use more and more. So thank you for that comment.
Thank you.
Amazing.
Great presentation.
Thank you. All right. So Arun's also saying, interested to hear offline how lung ultrasound users are finding the right lung volume using the imaging. Anyone want to take that one?
Yeah, I can take it if you like.
Wolfgang, yes.
I think
Yeah.
the easy one to spot is the atelectatic lung when you have an incomplete pleural line and you're seeing surface atelectasis. And if we see that on a baby that's on the jet with increasing oxygen requirements, we're going to run a recruitment maneuver in order to fill those lungs. The other thing, the over-distended lung is a little bit more difficult to pick, but we'd normally expect to see an intact pleural line with occasional B lines. If you're getting a predominant A line pattern, you're probably over-distended, particularly in a small baby. The other point to make that David made earlier in passing, I mean, I'm more into hearts than lungs, but basically, if you've got the optimal lung volume, you've also got optimal lung perfusion and you've got optimal left ventricular filling. So we also find that by recruiting the lung, we can improve cardiac performance as well.
Perfect. Anything to add to that, Arun, before we close off?
I was always interested in whether you could use it to assess how effective your strategies for pi are. So sort of start a strategy when you've got a hyperinflated appearance and then see if you can actually get it to step back into quotation marks a less aerated appearance.
I think it's fair to say that we've got more experience of the poorly inflated lung, which then inflates with a recruitment maneuver, than we do from an over-distended lung that then comes down. And that's probably because we're mostly on the jet anyway, and we try not to over-distend.
Okay. Thank you. Anything else, Martin?
No, I appreciate the discussion. It was really good. I was just looking at one question. Someone asked which conventional ventilator works best, and
Oh, sorry, that
my
was
answer
Parag.
is-
Sorry, Parag, forgot about you.
my
That's
answer is it's
robotics.
not which ventilator, it's which clinician is best. It's the operator, not the machine.
It's us, not them, Parag. Oh. Okay, so on the close off, two things. We have two Hippocrates in Vietnam and KL, and we'll have Daniel DeLuca doing lots of work on lung ultrasound. So if anyone's interested in joining, that's in November. And David's just advertised that he will have an advanced ventilation workshop at MCRI and Royal Children's at the end of August. And then if there's interest, they may run a jet-only workshop early 2025. I think you'll get a lot of takers, David. Yeah, thank you. All right, so we might let Martin go to sleep. I'll check the video recording. If it's okay, I'll post it up with David Tingay's article that Peter Dargable wrote. And yeah, that's it. Thank you for the robust discussion. It was excellent. Thank you, Martin. Have a
Thank
great.
you.
All right, bye everyone.
Bye, everybody. Nice to see
Bye.
y'all.